Hi, I'm Dr. Gary Huddleston, and I would like to welcome you to my website, www.trojantables.com, and I'd like to thank you for clicking on this video. What we're going to do here is show you in brief how to use the A.I.M concept, or adjusting in motion. Over the years, doctors have wanted an easier way to treat their patients, and I honestly think I found it. You know, for many years, we just laid the patient down on the table and adjusted them. Wouldn't it be easier if we could reduce the thrust by up to 40%? And we can do that by adjusting in motion. Now, the reason, like I said, I invented this, I've been building chiropractic tables for 30 years, and I wanted to do something better for me and better for my patients. This 20 or 30 minute video will give you a good understanding of how to adjust in motion, do stretching, and how to make your patient feel better with every visit. Doctor, let's look at a comparison of why adjusting in motion works so well. As chiropractors, we basically do two things. We put the vertebrae in motion and we give the vertebrae direction. How would you like to be able to do this with 40% less thrust? Let's look at it this way. Let's say you're in an automobile and you run out of gas. The car comes to a dead stop. You've got to get out of the car, get back, and push. Now, doesn't it seem to be a lot harder to push the car when it's stationary than if it's rolling and you get out of the car and go ahead and push? That's what adjusting in motion does. The electric flexion of the table automatically instills motion into the spine. So now, instead of doing half of the equation of putting in motion, all you have to do is give the vertebrae direction. You can actually adjust with 40% less thrust, and as we go along, we'll be doing a few other things like stretches and the spinal crawl that will also help you get more results with your patients. Now, one thing we also do here when I treat my patients or I teach this technique, I treat about 95 of my patients prone. I do all of my adjusting prone or face down and even my cervicals. I find it is quicker, less traumatic to the patient, and I get results just as well. I have adjusted up to 386 people per day using the A.I.M concept. And doctor, with just a little bit of practice, you can too. Now, let's get to the basics of the adjusting in motion concept. The first thing we want to do before you get the patient on the table is remove the guide handle and just set it out of the way. The next thing we want to do is help the patient get onto the table. I like to help stabilize the abdominal and the low back region. Now, you also want to make sure that the patient is positioned right. You can scoot up just a little, please. Good. And I like to have the break of the hips right at the edge of the cushion or between the lumbar and the pelvic cushion. And also you can come back here if you want to and do just a little bit of ankle extension. And I'm using the ankle strap as well. Lock that in place. Now, the next thing we want to do, put the guide handle back in here. And I want to start controlled bioflexion. As we said earlier, the UltraFlex AutoFlex has variable speed. You can speed it up or slow it down. I find about 10 to 12 flexion strokes a minute to be very comfortable, easy for the patient, and you can get good results. Now, if you have a very acute patient, you can also slow the speed down as well or adjust the stroke. The first thing I like to do is do the new Q4 axial vectoring. As we discussed before, there are 4 parts to the Q4 technique. The first of it is, of course, a P to A flexion in the back of the table. So we've already started part 1. The second vector is front lateral flexion. I will unlock here. Now, we can move the table back and forth. The third part would be axial rotation. This is the third vector. While axial rotation is not necessarily used a lot, it is good for detorquing or derotation type procedures. Now, if I want to, I can also go to the back of the table and instigate the fourth vector, or bring in the fourth body part, which is blast or bilateral axial spinal tensioning. By simply turning the crank, I can elongate or put distraction on the spine. I can put a lot, I can put a little, or none at all. And for the purposes of the video, Debbie really doesn't need long axis distraction at this time, so I won't use that vector. Now we do have, as you said, vector 1, the P to A flexion going up and down. What I really like to do is use the optional guide up here and laterally flex as the table flexes up and down and back. This is an incredible range of motion additive right here. Feels good to the patient, easy to do, and you can literally do it with one finger. That's how smooth this motion is. Now, after you've gone through the different vectors, let's start something else. This is what I like to do next. I'm going to lock the front half of the table in position now. What we're going to do is what we call a spinal crawl. And a spinal crawl is just what it implies. I am simply going to walk down the spine and go to each spinous process, make a contact as the table flexes up, hold it as the table goes down. Also, I'd like to say, to make it more comfortable for the patient, I'm going to pull out the lock, and now the gas shock spring abdominals in play too. So let's go back to the spinal crawl. I'm going to speed up the flexion stroke just a little. Now I'm going to just walk down the spine. Hold on the downstroke, release on the upstroke. Go again. This is what we call the 3 to 5 rule. I like to do everything either about 3 to 5 times. With the spinal crawl, you're probably going to get a lot of spinal releases that you'll be surprised at. Now, after I've done a spinal crawl, there's some stretches that we can do that are really good for the patient, and they feel good and they get good results. The first thing we're going to do is what we call a suboccipital stretch. This is very good for decompressing the cervical spine and also relieve tension in the neck, as well as help reduce headaches as well. All you do is contact beneath the occiput, hold as the table goes down, and release as the flexion section comes up. Just like that. Very simple and very effective. Now the next stretch we like to do is the cross-handed thoracoilium. And like I said, that is a cross-handed movement. One hand here, one hand here. Hold and stretch and relax. Hold and stretch. Go to the other side. Relax. Very good. Now, the last stretch I like to do is just a simple sacral stretch, where you can start at L1 in the sacrum and just walk down. Good. Now that we've done our stretches, we've done our spinal crawl, we've done the Q4 axial vectoring, which I also like to do at the end of the treatment to help set the adjustment. Let's go to the actual different categories, the cervical and pelvic categories. And as you notice, I do everything with the table in motion. The first thing we want to do is check the leg lengths. We're going to check our pelvic categories. And I'm going to come to the end of the table and check the leg lengths. This patient has a left short leg. So for simplicity, this is a left pelvic potential 1. Now, if I check the legs again, let's say the right leg was short. This is a right pelvic potential 1. Now also what you want to do is when you check your categories, you want to make sure you have access to the legs and you can shake the legs out. So let's just determine that this patient has a left short leg or a left pelvic potential 1. Before we can actually do any correction, we need to check the cervical category. This is a combination of a tie-in between the cervical and the lumbars or the sacrum. So let's have the patient turn their head to the left and leave it there, please. Now you want to shake the legs out and check. Okay? The legs did not level. So what we want to do is have the patient put their head straight down, turn the head to the right. Now shake the legs out again, and let's check it. Now when the patient turned the head to the right, the left leg shortened out or corrected and became the equal length of the other. So we have a left pelvic potential 1 and we have a left cervical synchrony. Now, even though she turned her head left, the reason we call it left because we always determine by the contact. Now we need to determine if it's a C1 or C2. And what you can do is just palpate down the spine and find a tender area, and this would be a C2. Now this table has a cervical drop, a toggle drop on it. So what we're going to do is I'm going to have the patient turn their head towards me, cock the drop, and make the correction. You can also do this correction supine if you want, or prone if you want, excuse me, face down, head over here to the right, make the correction that way. Now, if you're not comfortable doing prone adjusting, you can toggle or you can turn the patient over. So what we've done here, we had a left pelvic potential 1, a left cervical synchrony because the patient turned their head to the right and the left leg level. We've corrected the cervical aspect of it. Now we need to correct the pelvic part of it. And this is where the pelvic drop comes into effect. I'm going to cock the drop, make a contact on the left side of the ala of the sacrum, and make a twerking move. Three times. Then what we're going to do is come down to the end of the table and let's shake the legs out again, and the legs are equal. Now what you can do, doctor, is you can go ahead and do any other adjustments you want to do. So let's take one more scenario here, okay? New patient is down here. We come down, shake the legs out, and check. We have a right short leg. This would be a right pelvic potential 1. Now, let's have the patient turn their head to the left, shake the legs out. The right leg didn't level. Patient puts the head straight down, turns the head to the right, shake the legs out, and the right short leg levels. So we have a right pelvic potential 1 and a left cervical synchrony because they turn the head to the right and the leg level. So again, what we're going to do is palpate at C1 or C2. This time it's much more tender at C1. You can make your adjustment this way, or if you have a drop on the table, you can use the toggle drop. So let's say we went ahead and make the adjustment, face down. We come back here again and shake the legs out, and the legs have corrected. So we have a right pelvic potential 1 and a left cervical synchrony 1, meaning we turn the patient's head to the right and the legs level. We palpated down to C1, and that was where the tender nodule was, and that was the area we adjusted. So now that we've done the balancing, we're ready to go and look at lateral lesions. So for example, a lot of times you'll have a patient come in, they'll be antalgic to the right with pain down the left side of the leg. This is a left lateral lesion. So what we want to do, let's say the patient comes in with left sciatic pain. What we want to do is unlock the front half of the table and flex it away from the lesion. You do not have to overflex laterally, just basically break off center. Lock it in place with one finger And now, let's do some controlled deflection distraction here. This may be a case where you want to use the long axis distraction on this patient as well. So we're going to make the contact at L4 and hold it and release. Hold and release. I'm going to go down to L5, hold and release. Hold and release. And back up to L4. L5. What I like to do, doctor, again, is a 3 to 5 rule. I like to hold each segment 3 to 5 times, and often you will get an audible release from doing this. Now, after you've done the lateral translation, we'll straighten the table back up and proceed onward here. Now, what we can also do is, let's say, general fixation work. As I said earlier, the spinal crawl is an excellent move for just general fixation. Your Q4 axial vectoring will also instill more ranges of motion into the body. So at this point, if you want to do another spinal crawl, you're good to do so. Now, what I also like to do next is palpation. I do a 3-finger palpation during movement. And what I do is I like to feel the center vertebrae and the vertebrae inferior and superior and see how the spinal motion is going. If you do find a fixation, you can palpate for muscle tenderness, as is on the right side. Make a correction as a stroke down, and simple as that. The main thing to remember, doctor, is you want to do the spinal balancing and check the pelvic and cervical categories at every visit. Then you're free to adjust what other segments you want. You can do side posture. You can do any other movements or adjustments that you feel is appropriate. So, doctor, this has just been a real armchair discussion of how to do the adjusting in motion concept. Feel free to call me or email me if you have any specific questions. Thanks for coming and hope to see you soon.